Hello, everyone. My presentation is on the effects of aquatic therapy on balance and gait in individuals post-stroke. So my research question is, in individuals post-stroke, what are the effects of aquatic therapy on balance and gait? For my scenario, I have a client who is at the center of achievement here at CSUN. They are already participating in land sessions that they offer and are hesitant to participate in aquatic therapy because they feel that they won't get the same results they would uh, in the land sessions. So for my search strategies, I use PubMed for my database. Within PubMed, I went to the advanced search section. I typed in aquatic therapy and stroke. From this, 63 articles came up, but they were irrelevant to functional mobility. I then filtered them to only show randomized control trials. And from there, it narrowed it down to 15 articles. The first three were the relevant ones relevant to the question. And then one of my articles was not found on PubMed. It was actually retrieved from a kinesiology 313 course that I took. So the first article looked at cuff weights for training people post-stroke with hemiparesis. It was a cohort study, and the participants were 21 hemiparetic individuals with their average age being 66, and they were 5 years after their first stroke. So the participants conducted 2 aquatic walking trials across an 8-meter pool. So it was 3 conditions. It was the first no weight, then a weighted cuff on the knee, and finally a weighted cuff on the ankle. The authors wanted to measure walking speed, cadence, step width, step length, and stride rate. And they found that the cuff weight on both the knee and the ankle allowed for faster walking speed. So for the appraisal, applicability strength was that the study population is similar enough to my clients, so the results can be applied. For the weakness, the intervention could possibly not be feasible if the facility did not have that 8-meter movable floor pool. For internal validity, they had well-defined exclusion and inclusion criteria, and they also reported their confidence intervals, but there was no power analysis conducted, so there was no way of knowing if the sample size was proper, and there were no follow-up assessments conducted as well. So my second article was a randomized control trial. So the authors wanted to focus on whether land motor dual task training or an aquatic one would be better for improvements in balance and gait with patients with chronic stroke. So they had 50 individuals with chronic stroke between the ages of 45 and 55. The experimental group performed a motor dual task training program, while the control group completed the same dual task training program, but on land. So they measured dynamic balance, spatial temporal gait parameters, which include step length, walking speed, and time of support on affected side. They found that the aquatic group had a significant improvement in dynamic balance and the spatial temporal gait parameters compared to the land group. With this study, the applicability strength, the intervention was described in enough detail to replicate. For the weakness, client eligibility could be a weakness since my client would not qualify if he does not suffer from chronic stroke. Internal validity, power analysis was conducted for this study, and they also used control groups well. For the weakness, there was no follow-up assessment, so there's no way of knowing whether the improvements were maintained after the intervention. And there was no mention of clinically meaningful improvements. And for my last article, it was also a randomized control trial. This one wanted to measure the effect of Halliwick therapy, which is a type of aquatic therapy, on functional mobility in subacute stroke patients. So they used 30 individuals in the post-acute rehab stage at least 2 weeks after their first stroke, with an average age of 65 for the participants. So the experimental group in this study had a combination of 3 Halliwick therapy sessions and 2 conventional sessions, while the control group performed standard physiotherapy, both with the duration of 2 weeks. They measured postural stability, functional range, functional gait ability, and basic functional mobility. All the outcome measures significantly improved for both groups, so there was no difference between groups. For applicability, the strength was that the outcome measures were conducted in a realistic manner. The authors took baseline data and then post-intervention data as well. The threat was again client eligibility. So if my client is not in the post-acute phase immediately after their first stroke, they would not qualify for this study. For internal validity, the observers were blinded and there was mention of clinically meaningful results. And for threats, the intervention was only 2 weeks, which is a short duration, and there was no follow-up assessments conducted. So now for the bottom line, the evidence suggests that aquatic therapy can improve balance and gait in individuals post-stroke. Hallowig therapy, motor dual task programs, and cuff weights can yield improvements if implemented. And then practitioners should also be cautious of these results as they were, most of them were from a short duration. So what further research should focus on is follow-up assessments after interventions to see if the improvements and results were maintained after the studies. And they should also focus on longer duration of interventions that would be similar to like the Center of Achievement, since most of these only had like a couple weeks on them. And that is all for me. Thank you guys for watching.